So welcome everyone. It is nice to see so many here today. This is the webinar hosted by the LCH Steering Committee, Updates on Novel Biomarkers in Langerhans Cell Histiocytosis. Next slide. Just a little bit of housekeeping. The Histiocyte Society is a nonprofit group of over 200 physicians and scientists from around the globe. We are committed to advancing knowledge and improving outcomes for patients with histiocytic disorders with a focus on clinical and basic research as well as education. And this session is hosted by the LCH committee and the scientific committee and the Histiocytosis Association. Next. Just a bit of housekeeping before I turn it over to Dr. Olga Slater, who's going to be chairing the session today. You are muted. Please submit your comments via the chat feature. That's this red box that should be along the bottom of your screen on Zoom. After clicking, the chat window will pop up on the right, and you can type in your message and press enter to send it. Next. If you have questions for the speakers, there's a second box on the bottom. It may be in a different location on your screen, but it should be on the bottom called Q&A. Please put your questions in there. If your question has been answered by someone else, you can like that question in the Q&A box. And due to time constraints, we may not be able to answer all questions, but we do encourage email dialogue with the speakers after the session if your question wasn't answered. If you have technical questions for the staff, put those in the chat box. Next. Okay, I am delighted to hand it over to Dr. Olga Slater, who is going to set the stage for where our gaps and needs are in terms of biomarkers. So all yours, Olga.
Right. So, hello, everybody. Good morning, good afternoon, or good evening, wherever in the world you are. Thank you very much for giving me this opportunity to talk to you today about basics of biomarkers in LCH and neurodegenerative LCH, and then to sort of expand a little bit on our abstracts that we seen in Stockholm, but which haven't been presented, and then to take questions from the team. So that's exactly what we're going to do. So what do we use biomarkers in LCH for? First of all, to aid our diagnosis, to aid our potential therapy, especially therapy in refractory disease, to evaluate our response to treatment, to help us with weaning of inhibitor therapy, especially in Europe, to assess the disease during surveillance, to perhaps diagnose early the reactivation, then for early detection and early therapy of neurodegenerative LCH, to detect response in neurodegenerative LCH, and then very ambitiously potential prevention of neurodegenerative LCH. So we all know about mutations in the MAC pathway. There have been two large papers from the French group and from a Dutch group, which really have very similar results and which are showing that main mutation remain the same ones as we knew, with BRAF V600E most common, and then mutation is MAP2K1 and MAP2K2, and some different exons in BRAF and some rare BRAF alterations. Mutant is associated with various stratification in various types of LCH, but what is really, really important is that it is associated with neurodegeneration. As I said, the response to treatment is seen quite well in this paper by Paul Milne, published last year, which clearly shows that inhibitors decrease the level of mutant in peripheral blood, but don't eradicate it. and that the complete clearance of the mutant is possible with chemotherapy. What is also important is that presence of mutant in blood presents disease activity and increased risk of neurodegenerative LCH. The Vienna group has shown that BRAF in peripheral blood can be a very good way of monitoring inhibitor therapy, and a very good way of monitoring how do we do when we combine inhibitor together with conventional chemotherapy. And they indeed have managed to wean the patient off inhibitor therapy completely using cladribine and then maintenance chemotherapy. We probably don't need biomarkers anywhere more than in neurodegenerative LCH. I don't want to be bringing cold Newcastle, but I'd like to say, just for perhaps some people who are not too involved, that LCH is severe neurodegenerative LCH is severe complication of LCH. We can define it as LASI, which is LCH associated abnormal CNS imaging, or LCH associated abnormal CNS symptoms, which can include anything from tremors to ataxia, cerebellar symptoms, inability to write properly, dysarthria, and then behavioral and cognitive difficulties. Incidence depends on what we look at. If we look at the abnormal MRI changes, then the incidence is about 24% in last Swedish study. If you look at the clinical neurodegenerative LCH, then incidence is about 5.9%, which really makes sense because about 25% of patients with radiological MRI changes develop then clinical signs of neurodegenerative LCH. When does neurodegeneration occur? Late sequelae, 5 to 7 years after completing conventional chemotherapy. But what we're seeing lately, then patients with MAP kinase inhibitor neurodegeneration seems to happen earlier. What are the risks of developing neurodegeneration? So we know that susceptible patients are the patients who have CNS bone risk disease, patients who have DI, and patients who have skin involvement. This paper by the French group shows that 10-year neurodegenerative risk or cumulative incidence of neurodegeneration for patients with a BRAF mutation in the top graph is about 22%. But when you add to that BRAF mutation, so you have susceptible patients who also have BRAF mutation, that number goes up to 33%. So what do we do for early detection and for early therapy of neurodegenerative LCH? Imaging sort of seems to be too early. We've got changes on the MRI. Not everybody thinks that's good enough to start treatment. On the other hand, once we have a child who has developed clinical symptoms, that seems to be too late. So we really need help. And a kind of help, actually very good one, comes from Karolinska Institute in Sweden, and lately also from French group, in terms of neurofilament light protein as a biomarker of neuroaxonal damage. This protein can be seen in other neurological disorders where there is a myelin loss, especially in adults. So this is the previous paper published by the Karolinska group, and I'm sure Tatiana will tell us more about recent paper, where the levels of neurofilament light in CSF are above a cutoff level of 380. nanograms per liter, and which then drop down slowly once MAP kinase inhibitors are included into treatment. So we will hear more about that from our speakers, and I would like to introduce you to our speakers today. So first speaker is Tatiana Greenwood, who comes to us from Karolinska Institute, and who is going to talk to us about screening for the neurodegeneration in LCH with neurofilament light, but in plasma, not in CSF. So in something much easily obtainable, especially in young children who very often require general anesthetic to be able to have a lumbar puncture. Our second speaker is Professor Na Li, who comes from Beijing's Children's Hospital. She will talk about metabolites with potential diagnostic value in plasma of Langerhans cell histiocytosis children with posterior pituitary involvement. Her team has investigated if there are early diagnostic markers for posterior pituitary involvement in LCH, and they have found some interesting metabolomics sequencing that might help in answering this question. And our third presenter is Dr. Howard Lin from Texas Children's Hospital, who will talk to us about clinical implication of circulating BRAF V600E precursors in Langerhans cell histiocytosis. And he will talk to us about clinical significance of finding the mutant in peripheral mononuclear cells at the diagnosis, so at the very beginning, and how that can help define clinical status of the patients. So thank you very much. And I would like to ask Tatiana to present her abstract. I have to say that this abstract has in the meantime been published. So congratulations.
Thank you.
I'll stop sharing.
So I'm going to try and share my screen and hope that works.
Yep.
Looks great.
Okay, thank you. Well, thank you, Olga, for a very nice introduction, and thank you for inviting me to speak today. And as you very nicely mentioned, the topic of my talk today is going to be about neurofilament light in plasma as a biomarker of neurodegenerative LCH. Okay, I can't move my, I can't move it forward. So let me try again. Let's see. Okay, for some reason it's not letting me move my presentation. Oh, now it's moving. Oh, okay, thank you. Right, yes, so this study, as Olga mentioned, was actually published last year, and it was published with Malin Svejer as the main author, and it's a united effort from Professor Jan-Inge Henter's research group together with Professor Kai Blenov and Professor Zetterberg's groups as well. So as you already know, inflammatory LCH is an inflammatory myeloid neoplasia, which is predominantly in children and can basically affect any organ in the body. However, it is, of course, the CNS involvement which we are most worried about, because the brain is a vital organ, and neurodegenerative CNS LCH is potentially has dire consequences. And it's also very challenging to diagnose, monitor, and treat. And Olga did already bring up a little bit about the incidence of neurodegenerative CNS LCH, and there is quite a wide range in the literature, everything from 4 to 24%. Which is, as you mentioned, published in our Swedish population-based study. But no matter what we look at, I guess we can all say that it's not an uncommon complication, and we may not be detecting all of them, and at times we're definitely not detecting them early enough. So at the moment, today's golden standard for diagnosing and monitoring CNS, LCH, and neurodegeneration is by MRI of the brain with the typical neurodegenerative findings on MRI, but then also together with neurological, neurophysiological, neuropsychological evaluations, and also pituitary function tests. Now, these methods are sometimes maybe too early, like Olga said, or otherwise maybe too late or not sensitive enough. So with this in mind, our group initiated by Jan-Inge Henter and then also leading it, decided to try and look for relevant biomarkers for neurodegeneration in LCH. And in 2009, Gavhed et al. Published a paper on introducing neurofilament light as a biomarker of neurodegenerative CNS LCH, where they could show that the neurofilament light in CSF was higher in patients with neurodegeneration and also in those most severely affected. Neurofilament light, as you may know in CSF is actually a sensitive and well-established biomarker of neuroaxonal damage and is elevated irrespective of cause or the clinical diagnosis of the neuroaxonal damage. So in our studies of NFL, we also noticed that some of the patients with stable or progressive CSF NFL who were receiving different cytotoxic drugs actually did not really change very much in their elevated levels of NFL in CSF. So this study, which was published last year as well, which Olga also nicely mentioned, is with looking at NFL in CSF of 5 patients who developed, who had actually CNS involvement. And 4 of the patients, sorry, can you see my mouse? Are you, yes? Okay, yeah, so 4 of the patients had neurodegenerative typical neurodegenerative findings on their MRIs and verified neurodegenerative disease, patient 1, 3, 4, and 5, and they had continuously, or they had actually rather elevated CSF NFL levels. In patient 2, who only had pituitary involvement, we could see that this patient had lower but still elevated, pathologically elevated CSF NFL. And in these patients, it was similar to the previous I showed, where they were treated with several cytotoxic drugs, but even so, their NFL levels remained elevated. And in this patient, we could actually see rising levels of NFL in CSF as MRI findings of neurodegeneration were increasing. All of these patients then normalized their NFL levels in CSF with MAPK inhibitors, and some of them actually rebounded and got elevated again when they stopped treatment. Now, we could actually compare these patients with 12 patients who did not have known CNS involvement and who had normal levels of NFL in CSF. So for this project, we could conclude, this is how we sort of decided, okay, well, NFL and CSF does seem to be a useful surrogate biomarker to detect and to monitor neurodegeneration in LCH and is more sensitive. However, lumbar puncture is a rather invasive procedure, and therefore we looked at there was several studies that had been published about the nice correlation between plasma and plasma NFL and CSF NFL in other neurodegenerative diseases, and also correlations with clinical findings and radiological findings. So with that in mind, we went on to do a retrospective study of NFL in stored plasma and CSF in 10 patients with verified LCH, 7 children, 3 adults, where 5 of these patients were without known CNS involvement, and 5 of the patients had CNS involvement. 2 of them had definite, clear MRI findings of neurodegeneration, 2 of them with suspected neurodegeneration, and then 1 with only pituitary involvement. And for these patients, we had 19 paired samples of plasma and CSF, and we had consecutive samples in 3 of the patients. So we actually did not find any linear correlation between plasma and CSF NFL. However, what we could see is that the 9 samples that had elevated CSF NFL, so above 380 nanograms per liter, they all had corresponding plasma NFL above 2 nanograms per liter. And on the other hand, the 10 samples that had normal CSF NFL, 8 of those samples had corresponding plasma NFL below 2 nanograms per liter. So with this, there was 100% sensitivity and 80% specificity of plasma NFL above 2 nanograms per liter to identify elevated CSF NFL in our study. We could also see that the patients who had CNS involvement had higher levels of plasma NFL and CSF NFL than the patients who did not have CNS involvement. And when looking at clinical and radiological findings, we were able to see that the patients who had a plasma NFL below 2 nanograms per liter, they also showed an absence of clinical, cognitive and neurological symptoms, and also of radiological findings. Now, this one patient who had some plasma samples that were lower than 2, this patient actually had diabetes insipidus and hence also a missing bright spot on the MRI. But this patient initially actually had a plasma NFL above 2 when he was diagnosed with diabetes insipidus and had a thickened pituitary stalk then, which all normalized on MAPKI treatment on BRAF inhibitor. And then that's when he also had plasma NFL below 2. And then even though we actually didn't see any correlation between plasma NFL and CSF NFL, when we looked a bit more into detail, a bit closer into the patients who had consecutive samples, we actually were able to notice that the plasma NFL and the CSF NFL did seem to have follow somewhat similar trends, at least. And last year at the Histiocyte Society meeting in Stockholm, Jean Donadieu presented some very nice preliminary results on their study of neurofilament in CSF and in plasma in patients with neurodegeneration. It was a study of 93 LCH patients, where 1/3 of the patients with CNS involvement had neurodegeneration. And their findings were similar to ours, where they couldn't actually find an evident correlation between plasma NFL and CSF, but they did see that the patients with neurodegeneration showed higher levels of NFL in blood and in CSF. So to conclude, we feel that CSF NFL appears to be superior for the detection and monitoring of neurodegenerative LCH. However, plasma NFL could be useful perhaps for screening for neurodegenerative CNS LCH, where a plasma NFL level above 2 nanograms per liter, for example, could prompt the physician to move on to a more invasive lumbar puncture to get more sensitive CSF NFL levels. But however, a plasma NFL below 2 nanograms per liter could perhaps prompt you to wait with the more invasive lumbar puncture followed by blood screening. We didn't find a correlation between plasma NFL and CSF NFL in our study. And of course, we do feel that we need more studies on plasma NFL and even on CSF NFL to get a better understanding of these biomarkers used in clinical practice. So, and with that, I would like to thank you all the enthusiastic collaborators that we have in our teams. And also, of course, thank you, the LCH Steering Committee, for inviting me to speak today. Thank you.
Thank you very much. Thank you very much, Tatiana. It's an excellent presentation.
Thank you.
I can't see any questions in our question a little draw. While we are still at the subject on NFL, may I ask you a question?
Yes, of course.
Right. So I've got a group of patients, and I think everybody in the LCH world who speaks to me is probably bored of this question, but I'll ask it nevertheless. I've got a group of patients who have pituitary stalk thickening, and they have multiple endocrine deficits, including the eye. And despite extensive workup, we have never proven that they have LCH or indeed any other disorder that would be responsible for these changes and their endocrine deficits. Would you think that perhaps doing NFL in either plasma or CSF in these patients might bring some help to diagnose these patients? Because at the moment, I don't treat these patients with inhibitors or indeed with anything, and it's really frustrating to watch them have problems which are long-standing.
Yeah, I completely understand your challenge and your problem, because we have those patients as well. And I think for patients like this, I would probably say that if we had patients like that, we would probably look at NFL and CSF, just because it's more sensitive and we know a bit more about it. I mean, the plasma CSF is still, the plasma NFL is still in an earlier stage. And the problem with, of course, the NFL and CSF for these patients is that we might have an elevated level, but an elevated level is not pathognomonic for specifically LCH. So we don't know whether the neuroaxonal damage that we're seeing is because this patient actually has LCH as a reason for their pituitary stalk issues, or if it's actually some other condition. But of course, in the one patient that we treated, which we published previously, who had the pituitary stalk thickening, that patient, we did happen to catch him just when he developed his pituitary stalk thickening, and we did see that he did get elevated NFL and CSF when he had the pituitary stalk thickening, and then but we already knew he had LCH because he had a multisystemic LCH.
Of course.
Yeah. So in that, but then we could actually see that the patients who do develop pituitary thickening, they can actually get elevated levels of NFL and CSF. However, of course, we don't know really what the natural course of that is, because we put them on MAPKI treatment. So we don't know if perhaps if that patient, if it were to calm down, then it would normalize. But again, if he were to develop a bit more of neurodegeneration, which maybe is not really noticeable on MRI imaging, then perhaps an elevated NFL and CSF could be an indicator that there is still some neuroaxonal damaging going on. And in particular, once the pituitary stalk thickening has disappeared, because it normally eventually does resolve.
Yeah, it does, yeah.
Yeah, so that could be maybe, like, in that sense, it might be able to use it as an early biomarker. Yeah.
Okay. And we've got a very short question from Carmen Balestas, who is asking us if we can send this test to a non-research lab.
Well, the labs that we use, so this analysis we do here in Stockholm, and they also do it in Gothenburg, which is where the professors Blenov and Zetterberg are located. And there they are done on in particular in Gothenburg, on a non-research basis, both in CSF and in plasma.
Excellent. Thank you very much. It might be worth doing BRAF in peripheral blood at the same time.
Yes. Thank you.
Thank you very much, Tatiana. Now, moving on, we are moving to Professor Na Lin from Beijing's Children's Hospital, who will present her abstract.
Can you hear me? Good morning, everyone.
Hello.
Greetings to you. Thank you for the introduction. Our topic is metabolites with potential diagnostic value in plasma of LCH children with posterior pituitary involvement. These are our contributors. Our study enrolled LCH patient with posterior pituitary involvements, including the unclearly displayed, weakened, disappeared T1WI signal, second pituitary stalk, the occupation lesion. However, some manifestations, including uniform internal signal, pituitary stalk becomes thinner, skewed to the left or right, upper margin depression of pituitary. These manifestations were difficult to diagnose in time. Some patients caused rapid progression during their observations. Even some have scaly. So the pre-diagnostic markers were urgently to research. Now, metabolic studies on LCH patients were limited. Our research object was to find out potential pre-diagnostic markers of PI in peripheral blood of LCH children, and study the mechanism of PI and explore targeted drugs. In this study, there are 57 patients with LCH. This is the groups, including PI group, CNS risk group, NPC group. This is the sample distribution. We use the on-target metabolomics analysis. Our results have two aspects. Firstly, PCA analysis showed that the classification of patients was suitable. Then we will move to the part 1. After sequencing, this metabolites, including cellular processes, environment information processing, and other key GG pathways. Classification of the metabolites, including fancy arrays, tolylates, sterols, etc. PLSDA model shows that the comparison between two groups are feasible. Through these pictures, we can see metabolites in PI group have significant differences with the other groups. This is the heat maps of different metabolites in between groups. There are significant differences in metabolites between PI and other groups. Volcano plots of upregulated and downregulated metabolites in PI and CNS risk group. The upregulated metabolites in PI, including L-cysteine, vitamin A, etc. The downregulated metabolites in PI, including prostaglandin G2, A1, mevalonic acid, etc. They all trigger the pathway, including biosecretion, tyrosine metabolism, arachidonic acid metabolism, etc. Well, compared with the NPC group, L-cysteine 2,3-nautralic acid N-acetylglycosamine was significantly upregulated in PI group. In PI group, the triggered pathway was biosecretion, cysteine and methionine metabolism, ketotic acid metabolism, platelet activation, your active ligand receptor interaction, etc. Compared with the healthy control group, in the PI group, metabolites progranulin K1, D1, L-glutamic acid, thromboxane B1, B2, L-glutamine, L-tyrosine were upregulated. The triggered pathway including glutamine metabolism, AMPK signal pathway, cysteine and methionine metabolism, D-glutamate metabolism, citrate cycle, etc. Part 2, diagnostic value of metabolites for PI. After compare the metabolites in PI and CNS risk, we found that prostaglandin G2, A3, mevalonic acid may be better diagnostic markers, which involved in arachidonic acid metabolism and cholesterol synthesis. Well, compared with the NPC group, the N-acetylglycosamine and acetylcholine significantly upregulated in PI group, which participated in osteoblast hyperplasia process and release of adrenaline process. Compared with the healthy control group, we found that L-glutamic acid, D-glucosamine, and 6-phosphate L-glutamic acid were upregulated. They involved in the glutathione metabolism, alanine, aspartate, glutamate metabolism. We also analyzed the differential metabolites among the 4 groups through C-means cluster method. After clustered, the metabolites of cluster 1 were highly expressed in PI patients. We can see. We selected 8 metabolites in this figure, and the metabolites mostly involved in biosecretion, glutathione metabolism, etc. We also analyzed the metabolites of cluster 4, which was highly expressed in the healthy control group. In this group, most of the metabolites were FAH-FA family members, which have anti-diabetes, anti-inflammatory functions. However, we don't know why and how these metabolites and signal pathways were related to pituitary involvement. In the future, we will detect the specific metabolites levels in vitro and analyze the relationships between these metabolites and the prognosis of LCH patients. Metabolic pathways in vivo and new target drugs were our important objective in the future. I want to thank you, all the members in our team, and especially Professor Wang, Professor Zhang, and Professor Li. Thank you very much. Thank you for the organizer of the meeting. Thank you.
Thank you very much. Thank you very much for a very comprehensive presentation. I don't have at the moment any questions in my question box. It's definitely a different approach to biomarkers in LCH than we have seen in other presentations. Have you seen this type of investigations or research taken part in other neurological disorders?
Do you mean have other researchers on these aspects?
Yes. Have you seen research in metabolomics being taken up in other neurological diseases apart from LCH?
No.
No. Okay.
No, until now. Okay.
Thank you very much. Definitely space for numerous drugs, even not targeted, if you manage to prove your point in vitro and in vivo later on. Thank you very much to Professor Nali, and our third presenter today is Dr. Howard Lin from the Texas Children Group. So if you would like to, Professor Nali, if you stop sharing your screen, so Dr. Lin can start sharing his. Thank you very much.
Mm-hmm.
Can everyone see my screen?
Thank you. Thank you very much. I hope everybody can see Dr. Lin's screen.
I'm not. I'm still seeing.
So if you go in the middle of your screen at the top,
there we go.
View options, then choose to have a look at Howard's option.
Yeah, now we can see it.
Wonderful. Thank you very much. Take it away.
Cool. All right. Hello, everyone. So my name is Howard Lin. I'm actually not a doctor. I'm a doctoral candidate in Dr. Carl Allen's lab at Baylor College of Medicine in Houston, Texas. And I'm working in conjunction with the histiocytosis and lymphoma program at Texas Children's Hospital. And today I'm going to share with you guys some of the work our lab is doing in exploring the relationships between LCH disease genotype and clinical phenotype. And so just a quick refresher on what the MAP kinase alterations we typically see in LCH are. And so really the landmark kind of paper that came out in 2010 when Dr. Barrett Rollins and his group discovered that 57% of LCH patients harbored the BRF-V600E mutation really kicked off, where's my mouse? Really kicked off kind of the, and opened the doors for LCH research, and subsequent work by our lab as well as others in the field has really validated what he discovered. And today we find that around 50 to 65% of LCH cases harbor the BRF-V600E mutation. And since then, we've also discovered other MAP kinase alterations, such as mutations in MAP2K1 and ERBB3, as well as alternative mechanisms of BRF activation in the form of in-frame deletions, duplications, and fusions. And then also, more importantly, we reported that there's nearly universal activation of ERK in all LCH lesions, suggesting that it likely plays a central role in LCH. And so to really study the clinical associations of these different mutations, we have to first identify what those mutations are. And so building on our previous institutional pilot study at Texas Children's, our lab designed a staged approach to evaluate these somatic MAP kinase alterations in our pediatric LCH cohort. And so first, we extract genomic DNA from various sources, either FFPE or cell suspensions, and this can be from LCH tissue or pre-therapy blood. We're also looking at bone marrow and spit. And then we use a qPCR assay from QIAGEN to detect the presence of BRF-V600E. We also use ddPCR sometimes. And then for patients where we're unable to detect the BRF-V600E with one of those assays, we perform additional sequencing either through whole exome sequencing or targeted sequencing. And so what we found was really interesting. And so here's a summary table of the clinical characteristics according to BRF-V600E status in the lesion of 366 patients. And so in this cohort, we found that BRF-V600E in LCH lesions associates with a lower age at diagnosis and higher prevalence for multisystem and high-risk disease. And so to really walk you through this data, on the left-hand side of the table, you have the clinical characteristics that we assessed. And on the right-hand side, you have the p-value from a chi-square test to assess if there's any significance in the contingency tables for those categorical variables. And what I wanted to highlight was when you look at these highlighted rows, you can see the percentage and total amount of patients that we were able to detect a mutation in. For example, if you look at the high-risk patients, you can see that in 35 out of the 48 patients, or in 72.9% of the patients, we were able to detect a BRF-V600E mutation, whereas we are unable to detect a BRF-V600E mutation in 13 or 27.1% of those cases. And so altogether, this data really suggests a couple of things. And so this data really suggests that the mutation status of the lesion is important, but at the same time, it also suggests that the mutation subtype alone might not be the sole driver of LCH phenotype. And what I mean by this is we see an enrichment of high-risk patients, but what is it that makes the other 138 other patients who have the BRF-V600E mutation low risk? And so one of those factors that our lab believes plays a role in kind of determining this terminal clinical phenotype of LCH is the timing of when a cell acquires a MAP kinase mutation. And so this is a model for LCH pathogenesis that our lab proposed in 2018, which we termed the misguided myeloid differentiation model. And so this model was really based on our observation that patients with low-risk single lesion disease rarely had circulating cells harboring the BRF-V600E mutation outside of their respective lesions or in committed tissue restricted precursors, whereas only in patients with high-risk multisystem disease could you detect BRF-V600E positive cells in hematopoietic stem cells, as well as early blood myeloid dendritic cell precursors. And so really we suggested that LCH likely has an origin that's found in the hematopoietic bone marrow, and that perhaps we could use the presence of circulating BRF-V600E positive cells as a prognostic marker. And so this is a table that really is similar to the one we showed before, whereas previously we were looking at LCH lesions, we're now looking at peripheral blood mononuclear cells. And so this is the results from 294 LCH patients where we assessed the BRF-V600E status of pre-therapy blood using qPCR. And so in addition to the trends you saw earlier, you can now see a more pronounced difference in each of the different clinical categories, as well as strong supportive evidence for a misguided myeloid differentiation model. And so in patients who have multi-system disease and multiple lesions, you can see the evidence of circulating cells with BRF-V600E, whereas in patients with single lesions or single system disease, we're rarely able to detect BRF-V600E. And so this table is very similar to the one before it. The only difference is that we're now only looking in patients where we have detectable BRF-V600E in the LCH lesions. And so this is an important distinction because it shows that the same trends we saw earlier on the previous table, it's not biased by the patients who may not have circulating BRF-V600E cells because they just don't have a BRF-V600E mutation. And so you wouldn't expect a patient with a MAP2K1 mutation in their lesion to have circulating BRF-V600E cells. And so not only did we look at the relationship between BRF-V600E and clinical presentation, we also looked at its relationship to clinical outcome. And so when we compared the event-free survival of patients with detectable BRF-V600E in their lesion, shown on the left survival curve, with patients without detectable BRF-V600E, we found no significant difference between the curves using a log-rank Mantel-Cox test. However, when we look at the event-free survival of patients with detectable BRF-V600E in their circulating blood, we can now see a significant difference between the event-free survival with patients who harbor the BRF-V600E mutation almost 3 times as likely to relapse. And furthermore, this difference is still evident even after we separate patients based on the current risk stratification. And so this is important too, because it shows that this association of BRF-V600E with reduced event-free survival is not driven by the association of BRF-V600E with disease extent, and which we already know to be associated with high rates of progression or relapse. And so this really highlights the potential for the presence of BRF-V600E in circulating PBMCs as an independent prognostic biomarker in terms of LCH outcomes. And so to wrap things up, I really wanted to end by discussing where do we go from here and what our future directions are. And so one of the big questions you're probably asking is, well, what about the other mutations? We're very focused on BRF-V600E. And so here I wanted to show some data from a recent publication that was a result of our collaboration between our lab and Dr. Matthew Collins' group from Newcastle University in the UK, where we really show that the other MAP kinase pathway mutations are associated with the risk status of LCH in the same manner as BRF-V600E. And so here in this image, you can see the allele burden of MAP kinase mutations at diagnosis according to clinical stage. And so all of the patients who had multi-system risk organ positive disease on the right-hand side have detectable percentages of mutant alleles, and mutant alleles less than 1% were detected in 4 out of 7 patients, which you can see in the middle. And then, but we didn't find anything in patients who had single system disease, which is shown on the left. And so if you recall also, before I forget, all of these causative mutations of the risk organ positive multisystem LCH are present in the blood at diagnosis. And so currently, if you recall the tiered strategy that I mentioned before, we've performed additional sequencing on patients who were unable to detect the BRF-V600E mutation using the qPCR assay. And what we hope to do is really extend our analyses, like the ones you've seen before, to include these additional mutations. So hopefully we'll show kind of the same similarity or the same trends in MAP2K1 mutations, as well as BRAF in-frame deletions, as well as fusions and duplications and other MAP kinase alterations. And then finally, we also wanted to start looking at how the involvement of hematopoietic stem cell and myeloid lineages and allele burden correlates with risk and response to treatment. In this figure, we have the distribution of MAP kinase mutations among PBMCs from patients with multisystem LCH, showing the percentage of mutated alleles detected. And so this red shading really indicates positive fractions weighted by abundance in each sample. And so you can see here on this top row, you have the different kind of sorted populations. And so for each sample, we sorted for CD14 positive cells, CD16 positive cells, as well as dendritic cells, plasmacytoid dendritic cells, B cells, and T cells. And what this data really shows is that in both patients with BRF-V600E and MAP2K and the other MAP2K1 mutations as well, there's an enrichment of mutated cells in monocytes and myeloid dendritic cells. And so you can kind of see from like the second column and the fourth column where you have kind of 20%, whereas in B cells and T cells, there really isn't a really high allele burden present in PBMCs at diagnosis. And so this really suggests and reinforces the idea that myeloid cells with mutations play a direct role in the pathogenesis of risk organ positive multisystem LCH. And we are focused on really taking our biobank of blood samples and expanding on this in the future. And so right now we're sorting as many pre-therapy blood samples as we can get for these different populations and assessing the allele burden so that we can start to correlate these factors with different clinical characteristics such as risk, kind of single system, multi-system disease, as well as response to therapy. And so in conclusion, there's really strong evidence for the use of molecular analysis of the blood in LCH. We've shown that detection of BRF-V600E in the blood correlates with high-risk disease and is also correlated with a significantly higher chance of recurrent or refractory disease. And as we move towards a more personalized approach to treating LCH, we hope to expand these findings by interrogating the other MAP kinase alterations, as well as the allele burden in different immune cell populations. And with that, I'd like to thank my thesis committee, because I'm still a student, my mentors, the individual funding sources I have, as well as our institutional funding sources, as well as our collaborators and all the various cores on campus that have helped me with this project. And with that, I will take questions.
Thank you very much, Howard. It's a fantastic presentation. I hope you complete your PhD soon, and then we can legitimately call you a doctor. There is a question in the question box, so I'll start with that question. The question is from Astrid Balkalteren from Amsterdam. I'll read it out. Do you think the timing of blood collection is a crucial factor, whether or not BRAF mutated cells can be detected in low-risk LCH patients? Have you compared the sensitivity of your qPCR and ddPCR assays?
Yeah, so I will start with the last question. So we have definitely compared the sensitivity of our qPCR and ddPCR assays. One of our former lab members ran a series of, I think, 40 or 50 cases where he did both qPCR and ddPCR. And we found that the sensitivities were fairly compatible. They were pretty similar. But other than that, I don't have that much to comment. And then I guess the timing of the blood collection is a crucial factor of whether or not BRAF mutated cells can be detected in low-risk LCH patients. And so do you mean the timing of when the blood is collected, or when, I guess, yeah. So
I think Astrid is aware that all of the blood is collected, at least in your paper, before the treatment is started.
Yes. So all of the blood that is being collected is pre-therapy. So the patients have not received any therapy at all. And one of my peers, or one of my classmates, is actually kind of studying the changes in BRAF, in the allele burden of BRAF throughout treatment. So they're doing longitudinal samples as well. And so hopefully that'll be something exciting coming out. So that'll kind of give us a more definitive answer of how the timing plays a role. So you'll have the pre-therapy blood, you'll have throughout different therapies and longitudinal steps as well.
So what Astrid says, I understand, but it may take some time between presentation of the disease and the biopsy procedure.
Yeah, I think that could be true. And I think that's interesting. So I am not a clinician, but do you know kind of how long you should, so I guess what would be a good pre-therapy time? Like,
well, I think what Astrid might refer to is that children with high-risk disease are usually very sick and they present very quickly, while the children with low-risk disease, they might not be as ill, so the time to presentation might be prolonged. That might be the situation. We've got a question from Ruth Tatavosian from St. Jude's. Hello, Ruth. So Ruth says some MAP aberration in LCH may be driven by gene fusions or structural rearrangements. Could you extend these studies by performing NGS to identify these in addition to SNVs?
Yeah, so I think that's a great question. We're actually doing a lot of sequencing. So I'm in the genetics department at Baylor, so I love sequencing things. We are not only sequencing patients which were wild type for BRF600E, we're also sequencing patients that were positive for BRF600E to test whether or not these mutations are mutually exclusive. And we are also testing using next generation sequencing to really identify, let me see if I can go back to this pie chart. Yeah, so in this pie chart, we are kind of trying to fill out that 15% unknown, like you're saying. So if there's actually kind of like a secret fourth tier where after we've sent it out for qPCR, after we sent it out for additional sequencing and we still haven't found anything, we'll perform RNA-seq or next generation sequencing to really kind of try to identify that kind of 15% where we don't really know what's happening. And then we're also sending out additional samples that were B600E positive with qPCR for additional sequencing, because I know that there are some papers now that are kind of challenging the mutual exclusivity of these mutations. I think that was a much more succinct answer. Sorry.
Okay, thank you.
I think unfortunately, we're probably going to have to wrap up to be respectful of people's times. There's a couple of more good
Thank you.
questions that maybe Howard can answer via email. But I want to thank everyone for a fantastic presentations, and especially Olga for doing such a nice job chairing this session. Howard, if you can stop sharing, I believe that Kathy has just a couple more slides. So we've done the discussion. We want to encourage people who are not members to consider joining. And you can see the link there. I would like to thank everybody on behalf of the LCH committee for attending today, especially thank our speakers for the wonderful presentations, Olga for chairing, and Kathy for her amazing organizational and coordinating efforts. As always, it's always a pleasure to work with her. And I'd like to ask everyone to save the date for our next upcoming webinar. There's been a time change, but we'll be discussing EBV, chronic active EBV, and some potential new therapeutic approaches. Wish everyone a good day or evening, and we'll see you at the next one. Please do complete the survey that'll be coming to your email, so that we can provide educational activities that are of use to our members. Thanks and have a great day.